Okay, looks like we're starting to hold steady here, around 160 people. So why don't we go ahead and get started here today. Good afternoon. I'm Maria Monroe-DeVita. We'll do some intros here in a minute. And before we get started today, just a quick overview of our agenda. We'll do brief intros. We've got a very special topic for you all today with Lorna, focusing on a study that we're doing together on establishing benchmarks for ACT practice, and a national study that she is leading. And then we wanted to make sure that we allowed plenty of time today to focus on open mic. I know some of our last couple of presenters went a little bit longer. So we, on the one hand, had a lot more top content for you, but on the other hand, then kind of had to short shrift some of the time together to be able to kind of share with one another and ask questions. So we'll hopefully have a little more time to do that today. And then just a note that the last meeting of this year for the MHTTC is today until the end of our federal fiscal year here. And then we'll launch a whole new series starting in October. That's Monday, October 2nd, same time. Same place. And so we'll be sending out all of those dates and registration for the series in the next several weeks so that you can all re-register for those. So you'll have to re-register for the new series, but you will, because you're a participant in here, you will get that email to prompt you to register for it. Quick housekeeping, if you are joining us for the first time, everybody's muted and has video off. At some point when we get to the open mic, however, we like for folks to, raise their hands, and we're happy to even have you join us on camera and unmute yourself when we get to that point. But before then, it's pretty much muted and video off. We are recording. We'll share that recording here after today's presentation. The slides are also uploaded as well, and I'll make sure to share the link in the chat here in just a second with those slides. So a couple things about kind of how we're going to use today. Using the chat is generally for folks to just make a comment, or, it looks like we're using it for introductions and to know who's on today's call. But if you have a question, then we ask that you put it into the Q&A box, which is at the bottom, should be at the bottom of your screen. And that enables us to be able to track kind of who's asked what questions and if we've answered those questions, or in some cases we'll do it live. In other cases, if we don't have time or it's a pretty straightforward question, we'll just answer it within the Q&A box. But that's the place to pose any questions. If you put it in the chat, we may miss it because there's a lot that often gets put into that chat and it's really hard to track there. So put it in that Q&A box. And quick introductions to us. I know many of you have been with us for several years now, but just briefly, I'm Maria Monroe-DeVita, and I'm with the Spirit Lab and the Northwest MHTTC at University of Washington. And I'm a co-author of the Tool for Measurement of ACT, or the Team ACT. Also lead our training and consultation of our what we call PAC teams in Washington State, as well as train many of your teams, and I've worked with them quite a bit over the years. And it's good to see many of you on here today. And I'll turn it over to Lorna.
Yeah, hi everyone. So I'm glad to be back with you. And I'm the director of the Institute for Best Practices here at UNC Chapel Hill within their Center for Excellence in Community Mental Health. So I have a staff of about 16 trainers, consultants that work with teams across North Carolina, but also beyond, particularly with ACT, but also IPS supported employment. And then the other things Maria just said. So psychologist, mental health services researcher, and co-author of the Team ACT. And we're excited to continue to share a little bit more research from our national ACT study. A study that we've long wanted to do, and thankful that Arnold Ventures has funded it. And we are starting to wrap it up and get more of all this descriptive data to you.
Oh, you got some cheers here in the chat. So, all right, I'm going to turn it over to you then. And I will just sit here in the peanut gallery and make comments.
All right, let me see if I can navigate my share.
Good.
I think so. Does it look like what it's supposed to be?
It's not quite the slideshow yet. So I think you just got to click on slideshow.
Yeah, this is always the problem with too many. Let me stop the share so I can get it.
Okay, sure. And in the meantime, I'm going to just find that link so you guys know where the slides are and then put it in the chat here.
There we go. We're good.
Looks great.
All right, let's dig in. So the National ACT study is in year 4, it's final year, and I'm the principal investigator, and I'm joined with my co-principal investigators of Maria Monroe-DeVita, Lynette Studer, and Gary Cuddyback, and share a little bit more about this study. But first, we're going to be talking about fidelity and just making sure that we're all on the same page when it comes to program fidelity. Basically, what it is, it's the extent to which the defining elements of a program, model, or service like ACT, which has been previously established as effective, are implemented as intended. So I think of like a recipe. So a recipe tells you what are the ingredients, what are the amount of those ingredients, what's the quality of those ingredients, and what's the process of putting them together to then get you an outcome that should be desirable, meaning it tastes good, it feels good, good texture. So that's essentially what fidelity is doing as well. We know through research that teams that implement their ACT team with higher fidelity tend to have a higher probability of getting good outcomes, outcomes that they desire for the people they're serving, but also some within their team themselves. We also know through research that teams that implement to fidelity and also serve the intended priority population tend to generate cost savings, particularly for society at large when it comes to reducing use of crisis services, the expenses that come with homelessness, and also improving the number of people who are in competitive employment as well. We also know that fidelity helps us better understand and interpret research, so that if you're looking at a study that says that they studied 30 ACT teams, if there's measures of fidelity, you have higher confidence that they actually measured this thing called ACT versus a partial implementation of the model. Research also helps us with fidelity better understand all those variables that can go into the success or the challenges of implementing and sustaining ACT as well. Finally, fidelity helps us with innovation. So you may have a recipe that has shown to produce these good outcomes, but maybe you want to make it a little spicier. You want to change it for an intended population. So you take that original recipe and you make thoughtful changes and adaptations to better suit that specific need. So we know that we've had different adaptations and innovations with ACT, such as developing the forensic ACT model. So with this study, we have 2 studies. I'm going to start with talking about Project 2. And what Project 2 is, where we outreach states that had been using the tool for measurement of ACT or Team ACT, so the fidelity tool that Maria, myself, and Greg Teague developed. And we asked them to share information with us, which included the final reports that had the ratings in them, as well as the data collection tools that were used to gather information from the team before they went on site and did the review. So within that would be what we called the team survey and an Excel spreadsheet that had de-identified listings of different experiences the clients had, whether they were in competitive employment and so forth. Because we were unfortunate to start this study basically right before the pandemic hit, we decided to toggle our request to get fidelity data that went back as far as 2015, but was as recent as March of 2020. So it was one set of data per team out there, not getting multiple years of data for a single team. So what we ended up with is 11 US states shared their data with us. The number of teams per state ranges from 3 to 77. Altogether, we ended up with 222 ACT teams data in this part of the study. And in terms of representation, 10 of those states, so 10 of the 11 states, we had at least a third of their existing ACT teams we had at least a third of their data shared with us. For 5 of those states, however, we had nearly full, complete picture of their state. So we received basically all the team's data. The states that were implementing ACT and using the Team Act varied quite a bit in terms of how long they had been implementing ACT and how long they've been doing fidelity monitoring, but also they varied in terms of their intention of truly implementing ACT. So for instance, of these 11 US states, we had one where the data we have is more of a baseline needs assessment, that the area was trying their best to implement facets of the ACT model, but didn't necessarily have the funding in the direction of policy to be able to fully do ACT either. So for those of you less familiar with the Team Act, this is to give us a reminder of what's in the Team Act. So it's 47 items organized by 6 subscales. The first subscale is the operations and structure. It has 12 items, and there's some examples of the types of items in that subscale. And then we have core team, which 7 items. And the core team for us is leadership in the medical team, which overlaps. So your ACT team leader, your psychiatric care provider, and your nursing staff. Then we have the specialist team, which has 8 items. Although we want to see specialization in a whole lot of areas, we focus our measurement on the co-occurring disorder specialist, employment specialist, and peer specialist. And then we have core practices, which is 8 items. The core practice subscale resembles a lot of what you would have saw on the DAPS, the Dartmouth Assertive Community Treatment Scale. Same with the operations and structure scale too. So it's getting at some fundamental practice in terms of level of care, frequency of visits, intensity of services, the provision of psychiatric rehabilitation services. Then we have the evidence-based practice scale, EP, that has 8 items. And so this is where we're getting into more capstone practice for ACT. We want to see that they are really trying to plug in what we know to be best practices for this population of people with serious mental illness. And so we're looking for evidence that the whole team is knowledgeable and practicing from a best practice of supported employment, providing good psychotherapy, doing good work, working with families and natural supports. And then finally, the smallest subscale with 4 items is the person-centered planning subscale. So this is kind of what's trying to understand how are we directing our resources to the people given their needs? You know, how much are we trying to really elevate people's self-determination, focus on strengths, and keep our eye on what people most want and need from us while providing a full breadth of care. The example on here of CP6 is to show you of what an item anchor looks like. So each item is rated across a 5-point behavioral health anchor, where 1 is no fidelity and 5 is high fidelity. 4s are good, 2s are not so good, and 3s are a big bucket of okay, is how we see it. When it comes to the ratings, which I'm going to be showing you, each of the items are rated on this 1 through 5 scale. Then you total up across all the items, and then you calculate the mean or average. And it's that average is what we talk about when we say a fidelity score. So here, it's a little blurry, but here is the big reveal of what we have in our data set for these 222 teams. So as the last column shows you, the overall average score was a 3.68. So about a 3.7 across those 222 teams. And if we look at each of these subscales, the operations and structure was a 4.19, which is good. And it's consistent what we typically see. It's kind of like framing of the house. You get clear directions in terms of the expectations around who you're supposed to serve, using a team approach to some extent, doing some, having a ratio of how many staff to how many clients. So there's some things that end up being more clear directions that can come out of policy when it comes to operations and structure. Then core team also was doing pretty well with 3.98. So again, this is our leadership and our medical team. Then we have the specialist team, which starts dipping down. So on average, across those 222 teams, we're dipping down now to a 3.4. So we're going below what we want to see. If you picture that 5-point scale, we're going now lower than the middle. This is, again, an area that teams have struggled with in terms of workforce, using folks in their roles as expected. So you may be called the employment specialist, but if you don't have an opportunity to actually provide employment services, we have a way in which we start reducing scores, because we're not going to credit the employment specialist for being that name only. We want to see that they're actually stepping in and being used in that role. Core practices also was lower at 3.53. And so again, these are those fundamental things around ACT with frequency of contact, the level of contact you're having with natural supports, providing psychiatric rehabilitation, like working on daily living skills. And then you'll see the evidence-based practice scale, EP, and that person-centered planning scale, PP, are the two lowest of the group. And again, this is not surprising to us when we looked at smaller data sets, because that's the type of theme we would see, that these tend to involve a little bit more sophisticated practice, learning the skills and knowing how to apply them, but also being used with some intention within the team to provide this level of care. And just to put it out there as a reminder, this is practice before the pandemic, because when the pandemic came, we understand that everyone had to shift to make sure basic needs were being met, and sometimes had to move back away from some of those more rehabilitative and therapeutic interventions to just make sure people were okay. So moving on a bit more, this slide is breaking out by state. So I mentioned there was 11 states in this data set. We de-identify, not going to ever call out which state is who. So state A here, and there's a bar here that's set to reflect that mean I showed you. So the mean across all the teams is at 3.68. So 3.43, so this one state on average was 3.43. State B is at a 3.29. State C is at a 3.24. State D is dipping down to 2.66. But now we have a couple of states that went over that bar at 3.76, 3.81. Then another one who dipped under at 3.04, 3.63, 3.68. So they're pretty much right at the mean. Then we have our highest one at 4.13. And then 3.97. So you're seeing variation here. So before, I'm just showing you a big pool of 222 teams. Now you're seeing that there's some differences across the states as well. This slide I'm going to show you now is a little busy, but it's trying to help show that despite the variations in total scores on average here, your lower performing teams compared to your higher performing teams, they start kind of clumping together on some of these subscales like OS. Like, you may have struggles in other practices, but you can do pretty well when it comes to the operations and structure. And arguably, other than the outlier of our state D here, purple, same is true for core team, that they kind of clump together pretty well. Where you start seeing the big spread is with the specialist team and the evidence-based practices, and also particularly with PP. You see a lot more variation in people's probably understanding, skills, and application of these practices being measured. Now I'm showing you those same states again, but now I'm ordering them based on how much support they appear to get within their respective area. So what we looked at is, by way of data that we were collecting through Project One, which I'm going to touch on shortly, we were understanding the extent to which in those states fidelity reviews were being conducted. You know, was it part of routine practice? Was there ACT policy? Was there language that really made it clear what is the expectation of being an ACT team in this state? Also, we looked at the degree to which the providers in the state had access to ACT training and resources. So the states that are in green, they were credited for having all three supports present at the time that these reviews were done, or back looking at least at the point of 2020. Then for blue, they had at least two of those supports. The peach, at least one support. And then the two in red, they had none of those supports. So as you can see, the fidelity, average fidelity ratings are cascading down based on the amount of supports you have. There's a few anomalies here, such as this 3.97 in blue. This is a state that the support that they were missing was the Clear Act policy, but the fidelity reviews and the ACT training resources were actually quite robust. They had exemplar centers that were as part of the training process of other teams within the state, and they've been doing fidelity reviews for some time now. Similarly, with the state that's 3.68, they have access to training resources, they have a clear policy, and they have fidelity reviews. Well, actually, which one were they missing? They were missing one of them. They were maybe missing the Clear Act policy. Yeah. So there's kind of rhyme and reason when you visualize this and start seeing, again, what those contextual variables that really can help with successful implementation and sustaining of ACT. Oh, I know what I was going to speak to 3.68. They had all the resources, but they're a state that had a drastic change in how they were funded, and that drastic change in funding ended up leading to their fidelity scores dropping, and they've been trying to climb back up since. So moving on to the National ACT Study Project 1. What this is where we're going around and trying to understand the state of ACT implementation in each US state, territory, and district. So we've been going out. Many of you have been badgered by us and met with us, and we appreciate you and filled out surveys, but we're taking all this information and we're trying to understand what is the accurate picture of what's going on, say, in the state of Georgia. And we're gathering that information from your state mental health authorities. If you have more county or more local level authorities, we try to reach out to them. We always want to get information directly from some of the providers. We did that with the National ACT Team Leader Survey, which many of you participated in earlier this year. And we also, if there's TA staff involved, we're trying to get information from several sources and then try to understand what looks to be the most accurate picture, and then look for trends across the United States as well. So here's where we're at right now with our understanding. This map helps you see how many teams are in each state, roughly, and which states don't have ACT. California and Nevada both have ACT. They've been a little bit more trickier to pin down approximately how many teams there really are. And part of this is a story that's similar in other states too. So what we can't fully capture here is to what degree are the states attempting to follow fidelity? How is their fidelity to the model? So you may have a state that has a whole lot of ACT, but maybe their fidelity is not that great compared to another state that has fewer ACT teams, but really have been trying to do it with fidelity too. But this gives you a sense of how many teams are across the United States. When we added this up, I would estimate that we have at least 1,000 ACT teams that call themselves an ACT team in the United States right now. Some states that are in the 1 to 4, it's not uncommon that they are states that have grant-funded teams right now. So they are in an earlier stage of implementation. They're trying it out. They have yet to secure statewide support to do ACT at that point. I feel like, the other thing that we have seen that's trending but aren't necessarily fully being captured by our study is CCBHC rollouts have also led to where states are trying to figure out, is ACT going to be part of that? What does it look like? How do we set that up? So that's been another kind of variable that's entered the picture, is the role that CCBHCs are playing when it comes to ACT implementation.
Maybe I could just add to that.
Yeah, please.
And that is that with the SAMHSA funded demonstration projects for CCBHCs, many of you may be part of this, where the previous requirement was that you needed to actually implement ACT as part of your CCBHC funding. And so we've seen this proliferation of, many states, asking to get training and technical assistance on ag teams that didn't exist before the CCDHC. And now they've dropped that requirement, but we're still seeing some of the, somewhat fallout, but also just trying to figure out kind of how to support those teams since it's less funding for implementation.
Yes. And if anyone is surprised at seeing Wisconsin sitting at the 1 to 4, it is because they are a state that has the original PACT model. They just celebrated their 50th anniversary last year. But Wisconsin's a state that has community support programs, CSPs, that have elements of ACT in terms of being implemented, but has never fully stepped into have policy and really direct implementation of ACT. And so when you are trying to understand who's really an ACT team there, it tends to be lower, but also it's a little gray because some of the CSPs have really made a concerted effort to try to be as ACT-like as they can too. So let's look at some of the trend information. We have a lot of data, so we are just slowly getting it together and starting to roll it out. So this is just giving you a little bit of taste of what's coming out of the team leader survey. So we had 381 respondents to this survey. We have no reason to believe that we didn't get responses reflecting a single team, multiple responses for a single team. They appear to be distinct teams. There's ways we can look at the data to try to understand if this looks like the same team, but three different respondents. So sometimes we'll use the language of teams versus participants. They represented 42 US states, DC and Puerto Rico. To better understand, try to capture the validity of what we were seeing, we have to start narrowing down who's part of the sample that we're going to analyze. So for instance, we removed people who stated that they had 2 or fewer years of experience working with people with serious mental illness to begin with. There's a lot of the questions that involve kind of having some foundational knowledge about the population being served. So we ended up removing those 8 participants from the pool of analysis. We also removed teams that were just so small. So ACT is a model, because it's designed to be this all-encompassing team approach, you really ought to be able to get to a caseload size that's going to be able to support operating this team approach multidisciplinary team. So we were pretty conservative on how many teams we eliminated, but we did eliminate 3 participants that said that their teams had only been serving 14 or fewer individuals. Sometimes these teams weren't even in an earlier stage of implementation. It's just where they were at. And so we also removed teams that appeared to be what we called exceedingly large. So 151 or more clients were reportedly being served. Sometimes you could tell that it may have been somebody responding on behalf of a larger part of the agency, or maybe there was multiple teams that they were speaking to, and it made interpretation of the data more difficult. So we ended up removing those 11 teams as well. Finally, we looked at teams that had reported, we asked about the number of full-time staff that the team had, as well as part-time staff, to try to calculate percent of vacancies, what percent of the positions are part-time, and so forth. We had some teams, only 3, that have responded, or participants that responded by saying that they had 30 or more full-time staff, which that's not really an ACT team. That's speaking to something beyond ACT. We have ideas of maybe how people get to that place of thinking that there's an extension of the team that includes all these other people, but they also were removed. So then we were left with 345 people in the sample, or teams, I should say. So the length of time in the current position for the person who filled out this survey tended to be pretty low. So this kind of speaks to a workforce challenge we've been seeing and hearing from you all. You can see that we have about nearly 30% had only been in their position for a year or less. And then we have additional 30% who reported being there 2 to 3 years. So we don't necessarily have a robust group of seasoned people who had been in this position for a while. The exception, of course, is we do have, up here, looking at 20% or so were there for 7 or more years. So we do have a subgroup that had been there for a while. Most of the people responding had indicated that their team was what we had called a standard ACT team. We did have some representation of forensic ACT teams, so 5% identify themselves as being a FACT team. Then we had ACT Light, so this was defined as partial implementation of the ACT model, and you may be going by another name. So 3% self-identified as being ACT Light. And then we had a range of other programs such as transition age youth, first episode psychosis, assisted outpatient treatment, homeless shelter teams represented this smaller group too. When it comes to team tenure, how long has the team been operating? As you can see here, we have over half reported at least 10 years that they've been in operation. And then we have nearly 10% that have been operating for 2 or fewer years. And then we wanted to better understand where the teams were operating. So one of the questions we asked was about the population of their catchment area. So the area that they're considered that if somebody lives here, we potentially would be serving them. And so based on the responses, we have 55% saying that their area is 200,000 or higher in terms of population. So we're talking city to big city, metropolitan area. Then we have 20% who indicated it was between 100,000 to 200. Then we're getting at 10% saying 50,000 to 100,000. And then we have 11% that said it was under 50,000. So we're getting a little more rural here when we clearly are operating with 50,000 as the catchment area. We wanted to understand the longevity of the staff who are on the team. At some point, I'm going to break this out based on team size because team size influences the reporting out here. But percent of teams that reported the number of staff who have been on the team for at least 3 years. So 27% of the respondents or teams said they had 1 to 2 staff who have been there for at least 3 years. Then we have, and also keep in mind that I only included here teams that had been operating for at least 3 years as part of this data set. Then we have a third who said, well, I have 3 to 4 staff who have been on the team for at least 3 years. And then 19% had 5 to 6, which is great. And 11% 7 to 8. And then a smaller percent of 6 had 9 or more. So clearly this has to be a larger team to ever be able to reach 9 or more has been there. But then we look at those who have been there for at least 7 years. So here we have 43% said that they had staff on there, 1 to 2 staff at least 7 years. So basically the lower group here is going to start shuffling upward is how to think of it, because you're looking at longer tenure on the team. And then we have a quarter of the teams reported that 3 to 4 of their staff have been there for at least 7 years, which is great. And then you have 8%, 5 to 6. And then when we're getting down lower, it's smaller. So again, I only looked at the sample of teams who had been operating for at least 7 years to be able to get at this number. This is something that the DAX measures, and we didn't include it in the Team Act, but we pay attention to it. We collect the data to understand it. That continuity of staffing can be so important to doing ACT well, because it's a complicated program. And as we showed you with the specialist team and evidence-based practices, it's hard to build on that knowledge and expertise if turnover is happening too fast. And you don't have an opportunity for people to have that kind of knowledge carried forward to continue to expand and influence the rest of the team too. We also asked about, when compared to pre-pandemic years of 2019 and earlier, to what extent has ACT staff hiring and retention changed during the pandemic? This again, I limited this to just people who had been in their position for at least 3 years, so they had that ability to reflect back. So here we have 41% said significantly worse, 28% said somewhat worse, 20% indicated no change, and then you can see it tail off there. So again, We hear this from you all. We see it when we visit teams, and this is just putting a number to it to reaffirm what you all have been saying. So that ends the data, the presentation of the data we brought today. I can guarantee you we're going to continue to put together more data and find other avenues to share our exciting responses. Let me see if there's questions though.
Yeah, there were a couple I actually started to answer, but also thought that you could elaborate. So one is from Katie Kirk, our friend in Maryland, asking about the 11 states who participated and kind of why some states didn't want to participate. And I explained that for one, it's only TMAC states, and the other is just ensuring that these are states that where there was a quality control on the data so that we could ensure validity and reliability. Anything else you want to add to that?
No, I think it's just the point that you said that if it's a state that said they're using the TMAC, but we aren't sure of, like, we have questions about whether the people conducting the reviews have gotten much training, how long ago was the training, and then on top of it, if we see the data and see that there's a lot of rating errors happening, then we may not be able to use the data. So that was very limited, but yeah, we first started with just the states that are using the TMAC back then that had data to share with us.
And then also recognizing that there are a number of states that aren't using any tool at all. So
yeah.
we're really pulling from a very small pool there. And then Amy had a question, and I asked to clarify. So I'm not sure exactly which part of her question is correct, but she says she's wondering if states with higher teams, so I'm not sure if it's higher fidelity or more teams, have ACT requirements in policy. So maybe we could, I mean, my sense is for higher fidelity, certainly that's what we're seeing, right?
Oh, so I think I understand the question. So with the higher fidelity teams on this list, I can say that, doing a quick check before I say it out loud, they all had decent statewide implementation. They weren't limited, like in terms of, because you can, if you're trying to boost up a state that has 4 teams and you go all in, it's easier to get their fidelity up. When you're trying to boost up states that have 20 or more teams, now you have more teams to work with, and you have a more of a chance to have variation across the practices when you add the number of teams in there. So I don't know if that's getting at what you're asking, Amy, but the higher fidelity teams that you saw here that were also then resourced well also happened to be states that had statewide implementation of Act 2.
Great, and she did clarify higher fidelity, or maybe both to some extent, but I would imagine with states that have more teams that there was some impetus for them to have that many. It's for both. She was asking for both. So you answered the question about fidelity and whether fidelity tied to the higher fidelity was tied to policy, but the other part of that question is or number of teams. If there were a lot of teams, does that tie to policy? And I think the answer is mostly yes, right? We see whether it's a DOJ settlement related to Olmstead or, state legislative funding, focusing on implementing ACT, or some, focus on reducing state hospital use, that there's often a policy and we talk about that. We talk to many of these states about kind of what was, behind kind of expanding ACT, and are they expanding ACT now, even as we speak to them?
Right. Yeah, the states that are darker blue on the screen tend to also be states, there may be some exceptions, that do have ACT policy. They have clarity of, like, here's how we're going to fund you. Here's the expectations if we're going to fund you as an ACT team. The ones that tend to be in lighter blue, for the most part, tend to lean more towards states that may not have as clear of ACT policy, but there's exceptions I can see there too. There's a few states on here too that we didn't really get the data that we were hoping for, and so we did our best to guesstimate given what was out there. So I could name those states, trying to think if there's any sensitivity of naming those states.
You're looking at me.
Yeah, I was looking for.
You may want to, I don't know. I'd hold off.
Okay.
As we finish it.
Yeah.
Finish the study first. Christine had a question about if either project measured the number of ACT participants related to the population size of the state. And she was looking at slide 12 and that. I know that's a big question we always get asked.
Yeah. We have like multiple databases right now, and one of them we are trying to calculate some estimates of need based on population density statistics, estimates that live out there in terms of likely what percent would be a population in need of ACT, and trying to use that to then look at what is actually being offered in that state to see the discrepancy. So we have a couple models that we've tried with this, I think, that are getting pretty close. We just haven't gotten to them and gotten consultation with other experts to be able to release or speak to them yet, but we are looking at it for the sake of this study. We're trying to understand a lot of contextual information. I mean, I've pulled up reports on, you know, the extent to which you have availability of, you know, even institutional options for psychiatric beds, because sometimes, you know, states are so heavy on it that you don't have enough ACT. And then sometimes it's gone the direction where you don't have much at all. And then the states are in kind of crisis mode of constantly having to serve people with such high needs that they can't ever develop into a high fidelity team because they're always almost like a crisis acute response team more than anything. So we're doing our best to try to really just tell the picture and the story of what we're seeing out there to raise awareness of why these different things are important.
I see a bunch of comments too, just putting out to the group, asking about questions related to, so just for you all to know, this is a great place. I think putting it in the chat is a great place to do this since the question was posed there and it's not something you're asking us to answer per se, but the question is about what folks have done to incentivize hiring for ACT staff. Are there certain strategies that have been used? And so already some people are responding to that in the chat. For example, hiring bonuses. So far, that's, I think, most of what has been shared. But feel free to share if you've got strategies for how you have handled, you know, trying to really recruit and retain these staff, these important staff in these teams. It would be great to share that. I think too, with hiring bonuses, it would be good to know what percentage or what amount that is, because I know hiring bonuses do not all compare equally. I know we've had some comparisons to some of our inpatient units, for example, where our ACT teams are comparing to hiring bonuses with the inpatient units, and they don't, you know, it's hard to compete because they're so much higher for inpatient. There was a question Katie raised. It's probably related to what I shared in terms of clarifying whether CCBHCs are not requiring provision of ACT level of care. And so just to be clear, I wasn't saying that they're not providing ACT level of care. It was more that with the grants, the demonstration grants that were awarded over the last several years for CCBHCs across the country, the agencies that applied for those in their kind of one of the provisions in getting that award was that they needed to implement ACT as part of their CCBHC. And that, if you look at criteria for CCBHCs, ACT actually isn't a requirement. So there was a little bit of a, you know, kind of question as to why that was a requirement necessarily for a CCBHC. It's not that, of course, across the continuum of care, it makes sense to have an ACT team in a CCBHC, but in terms of the award that the agency got and the amount of funding they got, to require them to not only stand up a CCBHC and implement an ACT team as part of that was, I think, called into question. And that's also why now going forward that SAMHSA doesn't require as part of the funding for the CCBHCs for you to implement ACT. But that's not to say that there aren't agencies that are now CCBHCs that aren't implementing ACT teams. It's just not using that very small amount of funding to do it. So I think that was the question. It was a lot to ask for very little funding, and a lot to do in a very short period of time of these grants. So hopefully that helps to answer your question, Katie, but please feel free to clarify if I did not. The other question here is the number of years between fidelity reviews that you consider as routine fidelity review, and maybe both of us can kind of talk about that, Lorna. Oh, go ahead.
Sorry, I keep going off.
Go for it.
I think they were talking about the use of language here, routine fidelity reviews.
That makes sense.
If I recall, routine here was not so much about the expectation of how long the follow-up period would be. It was more about there wasn't just one or two teams that were viewed as part of a one-off. Like the intent of the state or area was that all teams would undergo a review or were in the process of it. In terms of the time between, though, I think it varies quite a bit from what we've seen. And we asked this question in the study, is that some places it depends on what scale you're using. When you're using the DAX, you can do it more frequently because it's an easier measure to conduct and use to get the data and get the report back and the feedback. And the nature of the changes you're asking the team tend to be more structural, staffing, and so it's something that the research would say every 6 months in the beginning, but maybe going to every year. For Team Act review, because it's so much more resource intensive and you're giving a lot more feedback across all these different facets of ACT, we see it ranging anywhere from about every year and a half, but then even going up to every 3 years for teams that are doing well. So here in North Carolina, before the pandemic, we were basically toggling the frequency based on what your previous report said. If you're landing into higher fidelity, we didn't feel like we needed to come back as quickly. We still were offering resources, but weren't necessarily coming in to do a full review. I was going to also speak to Christine's question in here too. Not Christine, it was Molly. She was asking about the size of teams should be based on the population. So I think that's a good question. So there's the one question of how many ACT slots do you need given the population in your area or state? But then the other question is, depending on those slots, let's say we come back and say, you probably need 200 ACT slots. That could be 2 large teams, 4 small teams, a medium-sized team, a small, like you can configure that in a lot of different ways. So when it comes to making decisions about the size of your team, I think one of the things that we've observed, and I don't know if you've seen, Maria, is, sometimes based on the positions you're trying to find and hire. So for instance, co-occurring disorder specialists have been a position that a lot of teams have struggled to find qualified people to fill within their teams. So if you are operating in an area that needs 200 ACT slots, if you operated 2 large teams, you just need to find 2 qualified substance abuse specialists to operate within those teams. If you're operating 4 small teams, now you have 4 substance abuse specialists to find. So sometimes you're trying to think about, and I don't think a lot of systems do think about this, but what is the actual pool of my workforce in the area? Now with psychiatry, they're allowed to be part-time anyway. So you have a lot of psychiatrists that work on 2, even 3 teams part-time. The other thing that we are also noticing is that, especially in today's time when just things are just feeling so much more hectic, that if you're a small team or if you're a team at the large end of 120, you only have 1 team leader. And we're finding that maybe it's good to be able to focus on the large to mid-sized teams in terms of just the overall management of what the team's needs are in delivering resources. So sometimes we're noticing staying in that mid-size, the lower large range is good. Getting too large, it just gets so hard to manage the workforce of your team and the needs of the clients all at once.
Yeah, it gets overwhelming.
Mm-hmm. And the last thing too is we're kind of curious. We saw in the data set is there's just areas that have really small teams, and that's where we question, like, maybe there's some liberties being taken around who is considered part of the team, because if you're a team that's been operating for 4 or 5 years and you're saying that you only serve 20 people, it's hard to staff up an ACT team as intended and be cost effective while only serving 20 people. So probably what happens, which we look at in the Team Act, is the edges of who's considered part of the team starts getting very blurry. You're including people that we wouldn't consider part of the team, but they're providing services in support of the team, but they're not really part of the care coordination heart of what ACT is supposed to be.
Sorry, I was typing a response to somebody here. Hold on one second. It looks like we've got, let's see, let me just make sure there are a number of new questions here. I almost wonder if we should shift into some of the the open mic, because there's a lot of great questions that are both in the Q&A and people asking amongst one another in the chat, and maybe we could pull some of those out. So the open mic time, for those of you that are joining us for the first time, is something that we like to do where, you know, we'll stop sharing our screens and we'll open up the opportunity to raise your hand if you would like. So it's at the bottom of your screen there, right, should be, you know, somewhere kind of within the, let's see, where is the raise hand? It's right in the audio settings. Let's see, in reactions. If you click on reactions, that button, the raise your hand, you can actually pose your question live to us. We'll unmute you, and you can also go on camera if you want to, no pressure. I know not everybody's in a place where they can necessarily engage with the group of 220 of us in that way, but feel free to. And then we'll also kind of facilitate some of this discussion in the chat and Q&A that are already in there. So I think the one question that came up in the Q&A that I thought we could start with is the question about credential requirements for ACT nursing and whether most states require ACT nurses to be RNs. Many of their teams there tend to have difficulty recruiting RNs. And so in Georgia, it sounds like you require only RNs. We can speak to the Fidelity tool and talk a little bit about the fact that we do require in Team Act that they are RNs. However, recognizing that, you know, in many of these teams, this is such a huge core role, right, within teams. And so to keep a position like that open for months and months can really be a huge challenge for a team. And that's, you know, really where we see a lot more turnover as you're trying to kind of hire and you've got these unfilled positions. And so to meet Fidelity standards, we've also opened the door to, while on the one hand, having at least one RN on the team, especially in these larger teams that have multiple RNs, if you've got one RN that has at least a year of experience working with people with serious mental illness, you can hire LPNs to support that role. And while they don't count the same as RNs from a Fidelity standard, it at least kind of counts to some extent. I think it's 0.75, 75% of the FTE for every one full-time position. And at least then it allows for, it's not an all or nothing thing. You know, it's like, oh, too bad you don't get credit. No, you do get some. And I think, again, our idea there is that it helps to kind of protect the team from having, you know, these open, unfilled positions where, you know, this role is so central to what you need to be doing in the team. So is there anything more on that, Lorna, you wanted to share?
No, I was just listening to you while grabbing a figure and just sharing, because people were asking about what constitutes the different team sizes. So I just threw it in there to show.
Okay, great. And Christine shared too with DAX. So I had shared the Team Act with the DAX. They must be an RN, but an LPN can be counted as half if they're under an ACT RN. And I know we have the same issue here where it's hard to figure out how to address if there's only an LPN. And again, it is a limited scope of practice. So that is where we have to kind of be sensitive and careful. RNs do have a, you know, just wider range of things that they can do. And so that's partially why at least having one RN devoted to the team is pretty key. But it looks like both DAX and TMAX are kind of taking similar approaches in terms of at least counting part of the FTE of an LPN from at least within Fidelity reviews. All right, and some people are weighing in terms of if you've got RNs or LPNs there. And we've also seen MAs. I guess MAs are another role that we've included as 75% of one FTE, or we would count them toward Fidelity credit. Lorna, is this something you wanted to talk about, given the question that was about the size of caseloads?
I didn't need to talk about it. I just wanted to put it for reference so they understood who is in our data set.
Great. Yeah, I think that was one of the questions in here too. Okay, yeah, that was Melissa, your question. Hopefully we've answered that there for you. Okay, so another question, Lena from Michigan is saying that ACT team leads are required to hold a full licensure, so like an LMSW, and 2 years postgraduate experience. So that's their requirement. And she's curious about what other states require for team leads. And again, feel free to raise your hand. We'd love to hear from you. It's always nice to kind of hear voices on here besides our own echo chamber here. Or feel free to, again, put it, in this case, you can put your response if you want into the Q&A or into the chat for that matter, and we can track it that way. And again, I think we can speak to that from a Fidelity perspective, which is that with the TEAM Act, we do require licensure, and we do require, is it at least 1 year, Lorna? I don't know why I'm blanking on this. 1 year of experience with people with serious mental illness?
Yes. Right. So there's policy. So North Carolina, I was trying to confuse like what policy says versus what Fidelity. And also just to say, like when Maria says we require, it's to get a 5. Yeah. If you don't have a license and you meet the other qualifications, you get a 4, and 4s are good. So we kind of grade it a little bit that way.
Yeah, that's a good point. When we say it's required, that's important. Yeah, and I think the licensure is so key, and one that we've, sometimes get pushed back against, but at the same time, when you see kind of what a team lead needs to do and how they're supervising other team members, remember, they're the one that's doing most of the supervision of most of the other team members, especially those that are, coming in with licenses themselves and delivering, empirically based psychotherapies and such. So I think it's important to ensure that they've got that licensure to be able to support those roles. But again, we recognize it's a challenge right now. It's a huge challenge. We're actually going to be focusing a couple of calls that just focus on behavioral health workforce shortage within ACT teams here in the next month. So stay tuned for that. It sounds like that's a topic people are very eager to talk more about, and we're happy to facilitate that. Okay, another question for states with clear regulations, are there caps on the number of participants served per team?
It varies. Some are very explicit and some are not. So usually it comes down to, from what we've seen, it's how the team is being reimbursed oftentimes determines whether there's a cap, because it's kind of an expectation that they've calculated approximately how much it's going to cost to fund your team if they're paying a bundled case rate. And so they want predetermined caps set in places that aren't necessarily using a bundled case rate. I don't know if we see the caps as often.
Yep, great question.
And some places hang a bit tight on the ratio and not talk about a cap. And that's where it gets a little bit slippery slope for us, because that's when you end up with a team that says, hey, I have 25 staff and we're serving 150 people. And maybe the ratio works out, but now you've grown into something that starts questionably being quite what we talk about when we're talking about an ACT team.
And I'm going to go to Tiffany's question here because it relates to what we're also talking about. She's asking, what is the proper ratio for staff members to team members? I think you mean staff members to clients, people served on the team, I assume. This is a really good question, and one that Lorna and I were just talking about the other day, and that is that if you look at either of the Fidelity tools, the DAX or the TMACT, to get a 5, to get the highest rating, it's a 1-to-10 ratio. So 1 staff per every 10 clients. That said, I would say anecdotally, even before the pandemic, both of us have kind of had the same experience where teams that actually have done quite well and are able to really fully, not just high fidelity, but where you're really seeing them being able to kind of meet the needs across a range of different program participants. We've seen lower staff to client ratio, somewhere more around, or I should say lower client to staff, because it's the client number of clients has going down. So 1 to 8 is, I think, a little closer. Were we kind of landing there, Lorna? Anecdotally, yeah. And then we've seen again in the pandemic, this is something we want to talk to you guys about a little bit more. Katie said, well, can't wait for y'all to publish that. Well, that's the problem, Katie, is that this is anecdotal. So, I think even with this National ACT study, I don't know that we'll be able to get that fine-tuned, but I think this is kind of what we're seeing. This is our experience. And I think post-pandemic, we're really seeing that. So not only are teams struggling because they don't have the requisite number of staff to support clients, but even in teams that are large enough, we're seeing so many more complex issues coming up that are dangerous and challenging, and more deaths, of clients, and, fentanyl overdoses and all sorts of things, assaults that, we're really questioning. Actually, is 1 to 10, are we where we need to be with 1 to 10? 1 to 10 was based on a model that was a very different landscape. Going back to what Lorna was saying about the context in which some of these fidelity findings are understood. And so I think it's something that certainly requires more study, but it also requires, I think, more kind of thought about where we go forward as a field related to ACT. So I think we'll have to put a pin in that one, but that question, Tiffany, is a little more complex than you probably thought it would be. Let's see.
I read Doug's.
Okay, go for it.
So Doug was asking about, at a presentation in the past with the team, had heard somebody say something to the effect of, some people think every person who is eligible to be an ACT client should be an ACT client. And Doug said that resonated with him and wondered what we thought about that. Not having more context around where that statement was made, my instinct response is to say, it depends on how you wrote the eligibility. So I think one of the things we see is that sometimes policy or lack of policy leads to the ability to qualify a lot of people who meet the check boxes of what policy says in terms of eligibility, but really are not probably the priority population that ACT is best suited for. And so when there is a large entryway into ACT, you end up having people come on to get services that really don't either benefit from the type of services ACT provides, doesn't need this level of care. And what it starts doing is it starts diluting what ACT looks like for that team, and it kind of confuses the team. So when we come in and say, we don't understand why your frequency of contact and intensity of services is so low, and they're like, well, but I have 30% of my folks are like working, they have their own this, they're doing well. And so I think population and who you serve is super important when you're trying to also think about ACT fidelity, because it was designed with a certain clinical population in mind.
Yeah, great question. I did want to clarify, we did some back and forth in the Q&A with a couple of us about, there was a question about whether the team leader, if anybody's team leaders are required to have roles in other departments, or are most team leaders only assigned to the ACT team. And somebody clarified that yes, they really should be only assigned to the ACT team. And just to be clear, that is really the case. And certainly, again, thinking about Fidelity, that is something that we look at. To what extent is the team leader really just focused on their ACT team? They're not supervising other people, other clinicians that are outside the ACT team, or supporting other programs, supervising other programs, or seeing other clients. They're really dedicated to the ACT team. And for those of you who are team leaders, I think you all get why that's the case. You have a lot of hats to wear. You're the lead administrator on the team. You're the supervisor on the team. You're doing some clinical work. It's a lot to manage alone, just even as your full-time job, let alone, having to get pulled into something else. So that's the rationale for making that the requirement. Okay, Justine had the question about, were there any teams studied that were rural? Where they covered a large area, so put in a lot of windshield time to get to a few clients. For us and our small team, getting to 20 clients is considered for us to be big right now, but we only have a team of 3 full-time staff, all with dual roles, and then the med manager. Great question, Justine. Do you want to answer that, Lorna?
Yeah, so we did collect the data. We started to analyze it, but we have to go back and I have to update it. So how I plan to, it does matter. So I think that, first off, when you only have 3 full-time staff and then med manager, you're already limiting yourself in terms of how many clients you're going to be able to serve with having so few staff to begin with. So with the appreciation that you are able to get bigger and maybe get closer to a 6-person team when fully staffed, it is all a matter of math. The more time you spend behind a windshield, driving to get to someplace and hope that the person's there and it's not just a failed attempt and you don't see them, that takes time away from direct care you could be providing to somebody else. And so we did ask the question in the survey, what is the longest distance you go one way from the ACT office to see somebody? So what's the furthest you go? And then we have a follow-up question, given that time, so say it's an hour or 90 minutes, how many people are qualifying for being that far out from the team? And we started to do a crosstab, breaking it all up based on your catchment area. So remember how I showed you some teams are metropolitan, some teams are more smaller, 50,000 or fewer in terms of the catchment area. And then we broke it down based on the size of the team, and we started to look at this. And it was really fascinating to look at because it's telling the story that you're getting at, which is it's hard to do this work with a lot of people if we end up trying to spread ourselves too thin. So something's going to give when you're trying to be the all-intensive one-stop treatment shop, serving people with high needs, and you're driving 90 minutes to see 1/4 of your clients on the team. So this comes back to an earlier question about how many teams. We stand by the idea that not every person who, maybe this was getting at how Justin was asking this question, and I didn't see it this way. Not every person, I actually think Justin was asking us for this reason. Not every person that qualifies for ACT is going to get ACT because they may live in a part of your state that is just not feasible for something like an ACT team to ever reach. And I think that's a hard thing for people, policymakers, whoever, to sort that out, is because, ACT cannot be the only community outreach team in our service model. We have to have other service models that have the ability to go out to see somebody. We just can't give you the full intensive wraparound services because it's simply not feasible. So I think this idea of how you design your catchment area is really important for functioning of a team. So if there's a team that's outspoken to these other counties and there's enough people out there who need ACT and you have enough people living in group homes and places that want to get out, I would be basically implementing another team that can better serve those people who are closer and work to get people out of group homes and assisted living facilities so you can staff up the caseload.
And Justine has raised her hand. So Justine, I think that you did that on purpose. I know sometimes people raise their hand and didn't mean to. So I'm going to allow you to talk and let us know. Okay, there you are. So you just have to unmute yourself. Are you there?
Yep, I'm here.
Oh, great.
Um,
Did you want to clarify your question or have like a response to Lorna's response to your question about
yeah,
rural?
so
Okay.
just touching further on that. Yeah, so currently, so I'm in Iowa, and currently like our agency covers quite a big chunk of the state. I think it's like at a third of the state we have offices and areas that we cover. But the ACT team right now is only officially in 4 counties. And in some ways, you know, that is a hindrance because like I've identified many clients that are already in our agency that would benefit from ACT, but they're outside of those counties and say more of our, you know, north areas. And logistically, it's just not feasible to drive that far. But even within those 4 counties, you know, we are having a hard time growing our census right now. And, you know, I'm getting pressure from like CEO, say, for example, there's one referral that we got a few months ago that I don't believe that they're appropriate for the program. But my CEO is constantly pushing for us to admit them into the program just because it would be a number. But logistically, she lives in the way opposite end of our 4 counties, and like the corner. We don't have any other clients that are over in that area. Right now, we're lucky enough that they're all kind of semi-located, so we can hit them up in like a big circle kind of drive. But this person we would be driving like an hour to go see her and then an hour back. And if we're doing any other services with her, as far as, you know, like grocery shopping or, you know, anything like that, social outings, she lives in a very small community, like a couple hundred people. So then there's the driving to any populated area that would have any of those things. And she is notoriously, and I mean, she's been in our agency with, you know, therapy and med services and IHS for years, and is very well known for missing appointments, not showing up, very hard to get a hold of. And so just that alone tells me we're probably going to be wasting a lot of time and energy on this person, and trying to explain that to the powers that be, that, you know, I would take her knowing that, you know, she would be a drive, but the follow through and the commitment to the program itself, I just don't believe is there, because she's not even reliable to do Zoom for med appointments. You know what I mean?
Yeah, I think that this is a not an uncommon scenario we've heard of, and I think an important kind of what you're identifying. It really comes down to, like you're saying, could you see her? Yes, but to what sacrifice of other services to the other people you're responsible for because of the time that it's going to take? And the other consideration too is when we're enrolling somebody onto ACT, we are supposedly, for most of us, I know some teams out here may not be held to it, but You know, you are supposed to be, in a way, the first responder. You're on call. You're supposed to be able to, if this person needs daily contacts or near daily contacts because they're going through a near crisis situation, we're designed to be able to have to provide that high level of care. So the question is, if this person hits a point where they need that level of care, can you feasibly do that without sacrificing the care that you have to give to everybody else on top of it too? So I think trying to help communicate, like, it comes down to, because ACT is a contained team, it's all about resource allocation. You're trying to identify what people's needs are. The expectation is people's needs will vary within the clientele itself. Some need high level of care, and we should be giving them high level of care. Some people are getting lower level care for various reasons, and then there's everybody in between. But if you end up moving out all the indirect time too far, especially for somebody who it sounds like is really departing from your catchment area, it potentially has a real negative consequence to the care you're providing for the rest of the team. And I want to put out there that your agency heads may hear is, do you want to be in a liability situation defending that you were giving the highest level intensive care in the community, but weren't able to truly deliver it because there's natural limitations to providing ACT to somebody who lives so far away that you can't provide truly that level of care to?
Yes, exactly. And on top of that, you know, right now, one of the biggest pushes is, well, you have a low census, so you have the time to put into it. Well, we may have a low census right now through no fault of our own. But what about, you know, in the next few months when we hopefully, you know, get 10 more clients and we're still covering 4 counties, and this person sounds like she would be someone that would probably not maintain contact with us until she's in crisis. And then it would be needing all of our attention for, you know, who knows how long, and then dropping off again. And so, yeah, then we definitely be sacrificing the quality of care to our other clients. On top of, I always try to maintain that you know, in order for me to keep staff, I have to take care of them, right? So it's always, you know, that
Sure,
awareness.
yeah, I think that's another important consideration too. I think
that's going to burn them out. And, you know, if you have too many clients that are in crisis of various reasons, they're going to get burnout. And we know that's just, you know, a part of this, but taking that, I mean, ideally what I would want to do is, because our agency covers such a large area and we've identified there's so many clients out of our catchment area that would be good clients, is I would like to open up a second team in our north area. And then that way we can, like, have 2 teams in 2 different areas to really be able to do better services. But that's not even going to be a consideration for the higher ups because of financials. And right now they're going, well, currently you only have a handful of clients. Why would we invest all this money into?
I'm gonna jump in and hit a couple points, and then we have a few other questions, but I think this is an important one that a lot of people probably resonate with. One is, I think, you know, with the example that we're providing with the woman, you know, I want to just restate what I know a lot of us all know, which is we will be referred people who are going to be hard to engage and miss appointments and all like that. You just described the next client. But I think that what you're throwing in is the biggest issue is where she lives and the distance away from everybody else. Then you're throwing in that other consideration on top of it in terms of, even if we tried, this may not be very successful given what we know, but ACT teams are designed to try to engage folks who have been challenging in the past too.
Absolutely.
I think the other thing too, which this may be like just going down a deeper route, is I would argue in many places, there are people who need ACT. I think sometimes like shifting out of the because I heard like getting referrals, like going out to find the people who most need the service too. I think that's something that we focus on in the Team Act that was getting missed otherwise, was like, it's not just serving the priority population, it's actually actively recruiting and finding the folks out there who most need the service. And a lot of that is about community relationship building. There are people who are no doubt stuck in some crappy group home, assisted living facility. They're the 30-year-old in a nursing home with everybody else is 70 and above. And they could do okay in the community, even great in the community, if they got those wraparound supports. So sometimes it's about trying to get out there and find the people. And I think a lot of that is from community partnerships.
Yes, I am lucky enough in my position. I won't go on too long because I don't want to take over, but I've been lucky enough that prior to being a therapist and taking over this team, I was in case management and worked for IHS. So I have tons of connections with all of these, group home providers and county officials and all of this. So I have great rapport with a lot of them. Unfortunately, one of the barriers is, while I can look at, okay, I know all of these clients and I know they would be better served because your staff don't have the time, or maybe your agency isn't necessarily providing that specific individual identified need.
Right.
They would be better served in ACT, but getting them to agree to let that person go can be a barrier without burning bridges.
For sure. That's the other thing is, yeah, group homes and those places aren't always easy to have people leave the beds because they've come accustomed. It's a consistent source of payment. So that's another conflict of interest that happens too, for sure. Well, thank you so much for sharing that.
Thank you, Justine.
You opened up a lot of different topics there.
Appreciate it.
Yes.
Great. A lot of chatter going on. I want to make sure that I get up this slide because we want to get your feedback about how you want to spend our time together in the coming year. So Maria and I have been talking about how, workforce challenges persist. And you all have brought that forward. We know that that really undercuts the great work you want to do. And I know that we have something, I don't know, Maria, if you want to speak to, we have something we're planning around trying to have a special session that talks about workforce recruitment, retention, turnover challenges.
Yeah, we're going to host a 2-part series, maybe kind of thinking about it as almost like a town hall, where we're bringing together folks like yourselves, but also thinking about anybody who might be working within the system, who has control or power in any given like state or agency that could actually do something about some of the workforce challenges, to bring us all together to focus on ACT specifically. So we know there's a lot of things happening kind of at the national level that are focusing on the behavioral health workforce more generally, but we're really focusing more specifically on ACT because of the myriad of other things about ACT that make us unique and why we need to really focus and target our efforts more specifically to ACT. So stay tuned. We're going to be sharing those the dates for those the 2-part series here shortly. The other one that we will be also sharing is related to supporting ACT psychiatric care providers, which would again be a 2-part series, kind of, mostly smaller group because it's a subset of our ACT team members. But knowing that many of our psychiatric care providers, psychiatrists, nurse practitioners, other physician extenders are often kind of on an island to themselves within their team, and often also have a little less time devoted to being on the team. And so having a place for them to be able to come together and connect and discuss kind of some of the challenges and resources together. So stay tuned for that as well. We'll be sending that out to this group.
Okay.
You get setting up the poll. Do you want
I
me
was
to
trying to set up the poll, but let me back out and restart.
Sure. Sure. Maybe I'll just set it up here for a
Yeah,
second.
yeah,
instead of
set it up,
talking
'cause
about it.
it's not launching.
Yeah. So for our MHTTC for the next year, we're hoping to, or we're planning on, I should say, to continue these calls. So every other month, continuing these calls. Our next one again will be in October, the first Monday of every month, 12 Pacific, 12 to 1:30 Pacific, 3 to 4:30 Eastern. And in so doing, we wanted to ask you some questions about whether we need to really focus some of those calls more specifically to addressing some of the major issues that teams are experiencing, and like dedicating solid time to like in depth to these focus topics. And one of those topics is around safety and some of the challenges that teams are experiencing related to that. I think it also does sort of overlap with the workforce issue. So hopefully when we launch the poll here in a second, we're going to be asking, is it working? Is it no, it's not working? Well, maybe people could just put it in there in the chat if the poll isn't working.
Let me see. I'm trying
Okay.
to sync.
So hold that thought for a second.
Yeah, I don't know why it's not. So it may be a chat question for now, unfortunately, because I can't get the poll to go.
Yeah, so I think putting in the chat, so the questions are, maybe you could put the questions up at least that were there. What we're wanting to know is in these calls, so we're just focusing on these calls specifically where we're holding them every other month, you know, that option is, do you want to focus more in depth on this issue of safety within ACT teams and having some in-depth time that we're just really focusing on that issue? So some of you may recall, we started these calls because of COVID. And so those calls for the better part of 18 months or so were all about how to address COVID within ACT. So we're kind of seeing almost like a similar kind of situation. The second option would be B, which is new topics each month, kind of like what we've been doing, where it's more about breadth of topics. So it could be CBT for psychosis, or, you know, how do we work with families, that kind of thing. And then C is a combination of both, where some are going to be in depth and others are more broad. And then any other ideas that you have, I think, put those in the chat. And I would say if there are specific topics that you just want to hear about next year, put those in the chat. And then we'll take a look at them. Right now, our October is kind of a clean slate. And so we'll be looking at your feedback to be able to drive what we do in October. Another way to also provide some feedback here is to fill out.
Oh, it's live.
Oh, it's live now. It is working.
Look, it magically came up. So
okay.
I think I see the trend of what everyone's saying, but it is launched.
Yeah.
And so pollev.com/Lorna M. And then you just choose. So if we want to have the excitement of seeing it, but I already know, I think what people are preferring.
I feel like there's a lot of C.
There's a lot of C's.
Yeah. So a little bit of a mix. No, that's great, you guys. Thank you. We really, again, we want this to meet your needs. So rather than us coming up with a whole bunch of ideas here, it's important for us to have this grounded in a place that helps us to do this to support you.
And I was multitasking with the safety one. Did you set that up in terms of why we're talking about it?
Pretty much. I mean, I think just that we are experiencing so much. And I think we talked about it earlier too, like around the staff to client ratio, that we're seeing a lot of challenges around safety. And also just thinking about it does tie to the workforce issue, not just in terms of how having unfilled positions relates to increases in safety issues and being a very challenging environment to be working in, but it also doesn't help for recruitment, right? Nobody wants to work in for a team that, this is part of the issue, that safety is going to be a big issue. So there are multiple reasons why I think this is the case, and certainly something it feels like we're kind of coming against, we're in a crossroads, I think, related to this, as it relates to ACT. I'm also going to just put another plug for the evaluation here for this call. And yeah, it looks like so far we're still seeing that trend of C. Okay, well, maybe we'll keep this open for another minute, but also recognizing people need to go. We're at the top of our time here. Have a great rest of your summer, and we'll see you guys in the fall. And keep a lookout for registration for the next series, which will be then registration for the whole entire year in those 6 sessions with us for October to September. So looking forward to hearing from you guys. We'll leave this open just for a little bit longer if you want to vote. Thanks all. Gonna be a lot to pull from this chat later.
I know, huh?
Yeah. Is anybody voting still?
You know what? I can never tell. You can tell. They used to be able to, they changed it.
Yeah,
Oh,
because it used to tell you N, right?
they
Okay.
used to tell you the end, but I think we
Yeah.
may have an end of 19 if that's what that means.
Okay. Okay. That looks like it. Yeah.
So
Okay. All right.
definitely C
Yeah.
given the
Okay.
chat.
Yeah. Yeah. Okay. Data that will help us. Thank you, Molly. Great ideas. Yeah. Feel free to put other ideas for future topics. Each job role. Okay, good.
Yeah, when we Molly and others, we're sitting on a lot of data, and I think when we can start getting it all out, which we're already starting to think through the modes in which we're going to be distributing it, I think you're going to have data is power to be able to kind of grab it and start sharing the story and advocating for different things for your teams.
Okay.
All right.
All right. I think we're good.
We are
All right,
good.
you all. Great to get your feedback. Thank you so much. It'll be good to talk to you guys more in the fall. Talk to you soon.
All right. Bye.
Bye.